The House Appropriations Subcommittee on Health and Human Services will come to order. Clerk, please take the roll.
Chair Morse,
Here.
Vice Chair Martis, Representative Hood, Representative Brabeck, Representative O'Neill, Representative Puri,
Here.
Representative Farhat, Representative Price,
Here.
Representative Skaggs,
Here.
Representative Snyder,
Here.
Vice Chair Green,
Present.
Representative Bolin,
She's on.
Representative Meerman,
Here.
Representative Kuhn, Representative Steele. Madam Chair, you have a quorum.
Thank you, Clerk. Representative Skaggs moves to approve the minutes of March 13th, 2024. Hearing no objection, the minutes are approved. Welcome, everyone, this morning to our subcommittee. We are happy to have some presenters today on behavioral health, an issue that we know is of critical importance across so many spaces in this budget, and for the people of the state of Michigan, behavioral health is a critical issue, and so we are happy to have members of the department here and others to share with us their recommendations and their budget requests and just how we're doing in the state in the area of behavioral health. So right now, I will invite up Megan Gruen, Senior Deputy Director of the Behavioral and Physical Health and Aging Services Administration, Dr. George Mello, Senior Deputy Director of the State Hospital Administration, and Amy Epke, Senior Deputy Director of Financial Operations. Thank you for being here today, and when you're ready, you can go ahead.
Good morning, and thank you for the opportunity to be here again this week. My name is Amy Epke. I'm the Senior Deputy Director of Financial Operations at MDHHS. And this morning, as you mentioned, we're going to talk a little bit about Michigan's behavioral health services. And both in this presentation and our presentation later this morning, you'll hear us focus a lot on community services and why that is so important in terms of behavioral health overall. In addition, we're going to be talking about the state hospitals, and similar to our other presentations, we'll also be talking about the fiscal year 2025 budget recommendations. Before I turn it over to Megan, I just want to take a minute to pause on this slide to talk about Michigan's behavioral health services overall. 22% of adults in Michigan have a diagnosable mental, behavioral, or emotional disorder. So when we think about that, that's approximately 1 out of every 4. So if we look around this room, that could be 1 out of every 4 in this room alone. And so just looking at this diagram, we really want to focus on prevention and early intervention. That's really key in the formula of addressing behavioral health. And that is why in this budget you'll see so many investments around community-based services. In addition, we'll certainly have discussion around what's happening at our state hospitals as well. But again, our goal is really to make sure we're getting in early, providing that prevention, early intervention to minimize the need for the inpatient care longer term throughout our behavioral health system. So with that, I'm going to go ahead and turn it over to Megan to walk through some of the initiatives that are underway on behavioral health.
Good morning. Thank you for having me here today. Everyone deserves access to quality behavioral health care where and when they need it. And I just wanted to take a moment to thank the committee for the continued investment and support in our behavioral health programs for our Medicaid beneficiaries and for the people of Michigan. We truly believe that right now, with the recent support of the legislature, the federal government, our community partners and advocates, that we have an opportunity to really further strengthen the array of services currently available in Michigan and ultimately create the behavioral health system that we want in this state.
I'm sorry, Megan, can you move the mic a little bit closer? It's a little bit quiet.
For sure. Can you hear me now?
That's so much better.
Okay.
Thank you.
Excellent. All right. Well, in case anyone missed the first part, the takeaway there was thank you for your continued partnership and focus on behavioral health. So I really appreciate being here today. Michigan's behavioral health specialty system is complex. I wanted to take a moment and just talk about a little bit structurally where we're at. We have 10 Medicaid pre-patient inpatient health plans. We have 46 community mental health service programs, The populations that they serve is any individual experiencing crisis, so that's regardless of if they're in the Medicaid program, it's any individual in Michigan, adults with serious mental illness, children with serious emotional disturbance, and adults and children with intellectual and developmental disabilities. Also, individuals experiencing substance use disorders. Certified Community Behavioral Health Clinics, or CCBHCs, represent a new frontier that expands the traditional landscape to include individuals with mild to moderate mental health needs as well. This system in Michigan is complex, but it has many strengths that we don't see in many states. It is truly community-based. This allows providers to meet people where they are, develop person-centered plans, and partner with the community-based organizations. People do better when services are delivered in the least restrictive setting, close to home, and close to their support network. A couple numbers that we have in terms of people that are served in our system. The specialty behavioral health system serves over 300,000 Michiganders each year. This includes nearly 70,000 children at a time when rates of depression, anxiety, and suicidal ideation have increased over recent years. Over 160,000 calls, texts, and chats are received annually through our behavioral health crisis lines and peer warm lines. For perspective, this is more calls and texts than there are people in the entire city of Lansing. Yet each caller is given individual attention and support based on their unique situation and needs. We want to talk a little bit about our current behavioral and health initiatives and CCBHCs. The CCBHC model increases access to a comprehensive array of behavioral health services by serving all individuals with behavioral health diagnosis regardless of insurance or ability to pay. CCBHCs, or Certified Community Behavioral Health Clinics, were first introduced in bipartisan federal legislation championed by Senator Debbie Stabenow in 2014. The legislation established quality standards and a new provider type in Medicaid called CCBHCs, which would increase federal and financial support for access to high-quality care for those living with mental illness and addiction. A CCBHC is a specially designated clinic that provides a comprehensive range of outpatient mental health and substance use services. These clinics have a unique financing structure that allows them to receive reimbursement through Medicaid for the full cost of the services they provide. CCBHCs are also unique in that they are required to serve anyone who walks through the door, regardless of their diagnosis and insurance status. 8 states, not including Michigan, began their CCBHC demonstration journey in 2017. After several years of experience and promising early evaluation results, the Federal CARES Act of 2020 was passed, authorizing 2 more states to join the demonstration, Michigan and Kentucky. Michigan's CCBHC demonstration launched October 1st of 2021 with 13 sites. The Bipartisan Safer Communities Act of 2022 extended Michigan's demonstration through fiscal year 2027 and allowed states participating in the demonstration to add sites, which had previously been prohibited. On October 1st, 2023, with the support of this committee, so thank you for that, Michigan expanded the CCBHC demonstration by adding 17 additional sites. So we started with 13. We added 17, which brings us to 30 today and makes Michigan the second largest CCBHC demonstration site in the country. The fiscal year 25 recommendation, executive recommendation, includes funding to support a further expansion of CCBHC sites in Michigan, focusing on community mental health agencies and organizations with federal grant funding supporting CCBHC implementation and advancement. The CCBHC demonstration has brought significant transformation in Michigan's mental health landscape, leading to improved continuity of care, easier access to services, facilitated new collaborations and better care coordination, expanded services to mild to moderate illness, mental illness population, and standardized quality metrics. They are designed to serve as a safety net, affording care to anyone with a behavioral health need, regardless of severity, insurance status, or ability to pay. They must also provide crisis services that are available 24 hours a day, 7 days a week. CMS requires CCBHCs to provide a set of 9 core services in order to ensure access to coordinated and comprehensive behavioral health care. These services represent a service array necessary to facilitate access, stabilize crises, address complex mental illness and addiction, and emphasize behavioral and physical health integration. CCBHCs are able to do all of this in part because of their unique financing structure. Each CCBHC in the demonstration received a clinic-specific rate called the PPS, or prospective payment rate. The PPS rate is calculated using the actual cost of providing CCBH services at that particular site. Participating clinics are reimbursed this fixed rate for each daily visit a Medicaid beneficiary receives. The funding is flexible and intended to support the real cost of expanding services to fully meet the need for care in their communities. We wanted to show a map of where we are today with the CCBHC demonstration sites in Michigan. The sites currently in the demonstration are nonprofit providers or community mental health agencies that have applied and are able to meet the federal requirements for certification. I wanted to take a moment and acknowledge that there are currently no CCBHCs north of Lake County. MDHHS meets regularly with providers and community mental health agencies across the state and is committed to working with our partners up north if they would like to apply for the demonstration. This map is of CCBHCs, but there are other integrated care models for Medicaid beneficiaries, and I just wanted to take a moment to acknowledge that and some of our great partnerships up north. For the UP and Northern and Lower Michigan are participating in many innovative models like health homes, which work well in their communities. They are successful at providing care coordination and linking people to the care they need through this model, which has proven to be successful for the beneficiaries. Behavioral health home services are available to beneficiaries in 42 Michigan counties across 6 regions of the state. Up north, there are 12 health home providers, which currently serve all counties in regions 1 and 2, which is kind of the northern lower part of the Lower Peninsula and the Upper Peninsula. In terms of community impact, we do have some data back from the first year of our demonstration. So this is from the 13 original CCBHC sites. They provided over 1 million CCBHC daily visits. Many CCBHC sites have traditionally only provided specialty behavioral health services to adults and children with severe, chronic, and complex needs. With the mandate to serve individuals with any behavioral health diagnosis, CCBHCs were able to expand their reach and serve a new population. We saw people take advantage of services that were never available to them before. People were served in a different county than where they live. People who were not in the Medicaid program were served in a traditionally Medicaid system. And people with co-occurring mental health and substance use disorder received treatment in multiple services, all in the same location. In our fiscal year 2023 outcomes, as I mentioned earlier, Michigan is relatively new to the CCBHC demonstration. Nationally, this model has been operational for about 7 years, and national data has shown that this model has dramatically increased access to care, helped to address the behavioral health workforce shortage, expanded the capacity of states to address the opioid crisis, as well as the needs of individuals and families in crisis for any reason, reduced mental health-related hospitalizations, and promoted the development and growth of partnership with law enforcement, schools, and hospitals to improve care. In Michigan, we're starting to see some similar trends. The initial CCBHC demonstration alone saw a decrease in the number of people experiencing homelessness, a decrease in time spent in correctional facilities, and fewer emergency room visits for behavioral health. Access has been expanded to those with mild to moderate behavioral health needs, as well as those who are commercially insured or uninsured. Telehealth has helped broaden the reach of CCBHCs, as have their relationships with schools and community partners. As a result of the CCBHC demonstration, 82% of Michiganders now live in a county with 24/7 mobile crisis response. The impact of this cannot be understated. The CCBHCs in Michigan are building strong partnerships, and we're already seeing some promising early results of these partnerships and the enhanced focus on the whole person coordinated care. We wanted to take a moment and talk about a new benefit that we have in the Medicaid program for psychiatric residential treatment facilities. The behavioral health system should meet people where they are, and our continuum of care needs to be able to do just that. Too often, we see individuals stuck in inappropriate settings, not getting the services they need and the services they deserve. We see youth waiting in emergency departments, waiting for an inpatient psychiatric bed. We also see people who are in an inpatient setting, ready for discharge, but without the necessary supports to go home. Every child and family deserves access to behavioral health care where and when they need it, and that means we have to build a continuum of care that can deliver the right type and the right level of care at the right time. A new psychiatric residential treatment facility benefit was added to the Michigan Medicaid program in December of 2023. PRTF serves as a step up or step down placement for youth that are in an inpatient level of care. PRTFs are smaller, community-based facilities that can provide care for youth ready to be discharged from a psychiatric hospital, but aren't quite ready to be at home full-time. We have a similar program that is funded with general fund dollars for adults. And what these programs really do is that it's best for people to be close to home, close to their families, and close to their support network. Outcomes are better for individuals served and families when they are able to stay together. This is a very new program. The benefit was effective in December, although we were able to launch some of these services as a general fund benefit beforehand to get those services up and running, bring on providers, and be able to add this to the Medicaid program. We do have a couple impact and outcome numbers that we are very proud of in Michigan, and you can really see that we have already had some successful discharges since June of 2023, which is when we kind of started to be able to launch these programs. So 20 of those for youth and 42 for adults. And what is really exciting about this is as we're seeing people discharge from a PRTF or an ICTS, we are really able to see them go back to home, go back to their communities, and have the supports they need to be successful and hopefully stay out of an inpatient setting. I wanted to take a moment to and talk about workforce. As we visit with healthcare organizations across the state, there's one issue that comes up in every conversation: the healthcare workforce shortage. At the Department of Health and Human Services, we launched a workforce steering committee that has a very simple vision: develop and implement a comprehensive short and long-term strategic plan to address the healthcare and human services workforce shortage. We've developed an all-hands-on-deck approach to the workforce shortage, establishing a steering committee that has been broken out by various action teams, implementing quick and short-term fixes, as well as strategizing on longer-term ones. Just to name a couple, this is not a comprehensive list. There's a lot on there. I will not go through every one of them, I promise. But just to note a couple, we did launch a $3 million student loan repayment program for more than 300 behavioral health providers. We've awarded loan repayments to 75 healthcare professionals working in high-needs areas. We've collaborated with Michigan State University and Wayne State University to add 24 students to the psychiatric mental health nurse practitioner program. We have awarded 33 free primary care clinics with $12,000 each to support practitioner salaries, and had ongoing efforts to provide 85-cent hourly wage increase to direct care workers at skilled nursing facilities in 2024, and a $2.35 hourly increase in 2023. A few other of our workforce initiatives that are pretty exciting to us have focused really on cutting red tape and streamlining our behavioral health provider credentialing process to allow providers to practice at the top of their license and keep direct care staff with patients, not filling out unnecessary paperwork. Through a new Medicaid policy, Medicaid will now pay for behavioral health practitioners who received their degree and are accumulating hours for licensing and or awaiting Michigan licensure. Several efforts are in the direct care worker space. Michigan's direct care workers provide personal care, training, emotional support, and respite to an estimated 100,000 Michiganders with mental illness or developmental disabilities. We have launched a Michigan career portal to match direct care workers with employers and created new initiatives to support direct care worker training and credentialing programs, recruitment and retention efforts, and additional support for first-time supervisors. All of these actions are being taken to address either the short or long-term ways to improve recruitment and retention efforts. We will continue to work with our healthcare partners on this complex issue, and it remains one of the leading challenges for health systems and other healthcare organizations across the state.
I would, if you don't mind, we're going to pause there so we can ask direct questions about CCBHCs just to keep it sort of clean. And I know we have a couple questions. So Rep. Green, go ahead.
Thank you, Madam Chair, and thank you for being here. I appreciate the download of information that we have, right? A couple of quick questions as I'm looking at the budget. We're asking for an increase in funds for the CCBHCs. Are we looking at increasing sites or increasing the number of individuals coming to the current sites?
Yeah, fantastic question. Thank you. So what we are looking for in the budget is to add additional sites to the demonstration project. If additional individuals do come to those sites and we do see an increase, that is a wonderful thing and kind of already built into that structure. But we are looking to add additional sites. And so those will be sites that are either community mental health agencies or we do have SAMHSA has grants for a number of provider organizations today, and some of those organizations would like to come into the CCB HC state demonstration. There's some additional benefits that are in that. So yes, it will be to add sites.
Adding sites, okay. Yep. Roughly, I mean, you mentioned north of the Knuckles. Well, not those technical terms, but you mentioned up north. Is that the goals or what's where you're looking at?
So we will, to some extent, it will be who applies, right? And so we will have any community mental health association would be eligible, as well as some of those SAMHSA demonstration sites. Many of those are up north. In terms of our CMH, of course. So they will need to meet that federal criteria and apply. There is not a set number in the budget of how many, but we do, of course, have some experience at this point with bringing sites on and what that may take. So that could be anywhere around a dozen additional sites that we are looking for.
Okay, one more follow. Okay, I think the current funding model is the feds pay 76%, give or take. How long do we expect that model to maintain? And then what is the expectation after the 75% model? Are they going to drop it to 65 and then the state's responsible for the future? What's your thoughts on the federal funding model and how long that's going to continue to exist?
So the federal legislation does bring that enhanced match to the around 75% that you're talking about through fiscal year 27. These are Medicaid services, so they would be funded in the Medicaid program. But that enhanced match to the 75% is right now the federal government has that through 2027. If nothing were to change on that front, that would be the normal Medicaid match, which is around 65.
So then after 2027, the state would pick up that extra 10%?
That is what would happen if nothing happens at the federal level to keep that enhanced match.
Okay. All right, thank you.
Rep. Price.
Yes, thank you. My question was about the student loan repayment programs and the incentives that you have offered and plan to expand for people coming into the behavioral health care workforce. I was wondering if you could talk about any of the evidence that we have from other states or what we've done so far that these work to recruit and retain these needed professionals.
So that's a fantastic question. And Amy, do you want to take it or? Sure. So I will give it a start. So what I can tell you about some of these programs that are not necessarily in the administration that I oversee, but certainly something that we've worked on together because we hear from a lot of our providers that these are necessary. We have had student loan repayment in the state of Michigan for a lot of things on the physical health side for years and years and years, and those are programs that are run through the federal government. This was the first time we were able to really expand that to behavioral health providers, knowing that and a larger group of practitioners, I guess I should say. We certainly have programs for psychiatrists. And so we really heard the need from individuals on this. It is only one portion of the work that we're doing, right? But Amy might know the numbers off the top of her head, or we can certainly get those to you. But of the 300 people that we served, I think it was at least 3 times that, the number of people that applied, right? And so to me, that is saying that there is a great need there. And we have heard overwhelming support from our behavioral health providers in the field that are just saying, we need a couple things to help us, with this workforce and making sure people are getting the education they need to be able to provide these services.
Yeah, and I think the only thing that I would add on that is that we do continually look at the metrics associated with each of the programs as well in terms of placement and different criteria and accomplishments of each of the programs. And as you've seen on Megan's slide, we are taking a variety of approaches to make sure we know it's not a one-size-fits-all, but we do recognize the need in the workforce area and are committed to continually putting out additional approaches to make sure that we can help address that need going forward.
Rep. Steele?
Thank you. Just real quick. So you said the state of Michigan has the second largest facilities in the United States, and that we have increased the capacity. So it's a good thing that we have the care facilities, but it's a bad, why do we have the need for so much? And are we looking at to eradicate or be able to get people moving forward to not have to use the facilities by trying to fix the root cause of why we have 1 in 4 that need them to begin with? Is that part of the program? Thank you.
So, first of all, lots of states have different strategies on their behavioral health systems and how they deliver that care, right? CCBHC is definitely a model that Michigan has embraced. And, I am happy to speak to that model and kind of why we made those decisions in Michigan. I will say that the earlier we treat people, the better outcomes that we see. The greater ability we have to treat people in the community so that people are closer to their family, to their support systems, whoever that may be, the greater success we see. And so being able to deliver care in a non-institutional setting in an outpatient facility is something we have really wanted to invest so that we are seeing people kind of at that front end, that there's no barriers to entry, right? Like, that's really great, to have all of these different programs that are specific to serious mental illness, to serious emotional disturbance, to mild to moderate, and all those things. What if I don't know what I am? I just know I need help. And so a lot of what we have tried to do is make sure that we're taking down the barriers to that front door, right? So that people can go in and get the help that they need early, so that we are not seeing them in more restrictive settings later on that are not as good for the individual and the family, and quite honestly are also more expensive. And so those are some of the things that we're doing to help on the front end so that we are able to, as we look in the longer term, hopefully bring, as you kind of discussed, those root causes and things. Some of the root causes for people in institutional settings is that they got care too late, right? What could we have done earlier in that process? And so that is a piece that we have focused on quite a bit.
Rep. Farhat?
Thank you so much, Chair, and thank you folks for being here today. I'm looking through the presentation, and when we mentioned psychiatric residential treatment facilities and intensive community transition services, I really want to focus on residential treatment facilities. We have, and I want to make sure I'm talking on the right subject here as it pertains to, juvenile justice kind of related, and that's in this gamut, right? That's adjacent to this type of treatment, or?
Actually, I believe we have a separate presentation this morning on juvenile justice, and we'll bring up our juvenile justice experts on that conversation as well.
Okay, I just wanted to make sure I wasn't conflating the two, so I appreciate you clarifying. I'll save my question for that presentation then. Thank you.
Okay, thanks, Rob. So I am going to ask a quick question before we move on about CCBHCs. And the goal, again, is to partner with organizations that already exist, typically the CMH in an area, and then expand to mild to moderate, which we as a state have never really engaged in before. And as part of that, we have set up the PRTFs and the ICTSs. And there is some mention in there of the step-up access that you're trying to create, which is something that I have heard about a fair bit. For that sort of in-between, someone needs a higher level of care, but maybe they don't need to go to Hawthorne or, but they need something in between. How are we doing with access to that sort of facility?
So I think that there's a number of different initiatives going on, and I don't think any one of them is going to, solve that in every setting, right? So I think CCBHCs are incredibly helpful because you can show up and they will align and make sure that you're in the level of care that you need, right? And so you don't have to be, trying to figure all of those pieces out yourself, right? And so getting people access to that system. I also think CCBHCs are incredibly important. Delivering most of their services are, outpatient, right? And so as we see individuals that may have needed to be in an inpatient setting, if they are ready to be discharged, how are they then having that services at home in the community, right? Like they may not be ready. And so we have something like a PRTF, right? Or an ICTS that is still an inpatient level of care, right? You're still at that level of care, but we're kind of bringing on those community supports and getting you ready for that. And then a CCBHC and our CMHs and, community health benefits really serve for that next level, kind of as you're going through those transitions of care. And so I think that we need to be very careful to make sure that we're building all of those pieces at the same time, because if we have anyone stuck in one place, right, then it's kind of impacting where we are in the entire continuum. Another piece that is not mentioned in here is crisis stabilization units that the department has been working on for several years, thanks to some legislation that went through in, I want to say it was 2020, might have been 2021, but fairly recently, we have 11 sites that we have been working with to come online in, it is 72 hours that somebody can stay in a crisis stabilization unit, and that then they get either transitioned to an inpatient level of care if that's what is necessary, or make sure that they are transitioned to the community with the right support so that they can be successful. So I think all of these pieces need to happen, need to work together, right? And need to make sure that we're kind of building that continuum so that in the state of Michigan, there's someone to call, which is 988 and the MyCal Access line that Amy will talk about in our investments. So we have someone to call, someone to respond. That's when we're talking about 24/7 mobile crisis and those pieces, right? And somewhere to go for help. And that might be a CSU, it might be a CCBHC, it may be an inpatient level of care. But the important piece is that we're getting people in the right level of care where they can serve those individual needs.
And going back to Rep. Steele's question, which is root cause, some of the root causes are things that you can connect people through community supports. If it's food support, food insecurity, housing potentially, whatever other services, the CCBHCs are engaging in that work as well, correct?
Absolutely, yes.
Okay, well, thank you so much. We're going to move on to Dr. Mellows. Thank you for being here. Thanks for your patience.
And thank you for having me today. We'll go over the state hospitals and certainly answer any questions you might have about those. We have in the state now 4 state hospitals. Hawthorne Center closed on July 1st of 2023. It is now, the children's beds are now at Walter Reuther Psychiatric Hospital, and at Walter Reuther, there's a children's division and an adult division. That facility, as you know, is located in Westland in Wayne County, and they have an average of about 100 adult patients at a time and approximately 30 child patients. And the children's beds serve the entire state. The adult beds serve the southeastern Michigan counties. We also have an adult facility, the Caro Psychiatric Hospital in Caro, Michigan, in Tuscola County, that serves on your map all of the blue area. And Kalamazoo Psychiatric Hospital, Western Michigan, located in Kalamazoo, serves the western counties in the orange color. And then finally, the Center for Forensic Psychiatry, which is in Saline, just outside of Ann Arbor, serves primarily a forensic process population. To be clear, our adult beds in all of the state hospitals are about 50% forensic process, 50% probate process. Of course, all of the children are probate, very rarely forensic process patients. And if you look at our numbers, about 600 patients altogether, that gives you a sense of the scale of how small we actually are in compared to the rest of the behavioral health care delivered by our system in the state of Michigan. As some of you who have been on the committees for a while are aware, our facilities, Hawthorne, Walter Reuther, Caro, Kalamazoo are very old facilities. Indeed, parts of Kalamazoo were built in the 1850s. And we have been able to, through the work of the governor's office and you, secure funds for building a new facility at Caro that we moved into, a 100-bed facility that we moved into last year, which is a state-of-the-art behavioral health physical plant, and are doing the same thing through ARPA funds in southeastern Michigan, and hopefully will be in our new facility in Northville, located at the old Hawthorne Center campus. And the construction began in December after the facility was demolished. The building will turn over to us from DTMB. They, of course, are managing the building of the new structure in June, July of 2026. Picture of an image of the site at where the old Hawthorne used to be. The new facility will sit on that flat part of that structure for any of you who might be familiar with the grounds there. It's Christman is the construction company that DTMB is working with. The facility will be divided into a north section and a south section, connected through an administrative complex, and approximately 500 parking spots for the 800 to 900 employees that we will have there and patients. This is an image of what the front will look like at the facility. We will have 192 adult beds, 72 pediatric beds. That's a net system increase of about 54. There will be 8 adult units, 3 pediatric units. The central administrative complex will divide the essentially 2 facilities. They will not be accessible to one another. The facility, like the new Caro facility, is patient-focused with downtown and school areas, and large meditative and recreational spaces. Again, separate adult and pediatric living spaces, treatment spaces, and what are called downtown areas, the school area and the psychosocial rehabilitation section for adults. We have a model in place, having just been through this with Caro about moving from one facility to another. Next year, we will begin to look at all of the standard operating procedures at Walter Reuther and review them carefully so that they are ready and in place for our move into the new facility. There will be a very significant records and material reduction plan in place. In the winter of 2025, we will, with DTMB, contract with a mobility service and begin the planning to actually move one facility to the other, and then In the summer of 2026, after the building is turned over to us, we will begin staff walkthroughs and trainings with our staff so that they are actually trained in the new facility live with those reviewed standard operating procedures. We'll stagger our move to the facility September through January, September of 26 through January of 2027. These moves are carefully planned and as we learned from Carol, can be done in a way that it does not traumatize patients or staff.
Thank you, Dr. Mellis, for that presentation. We'll take a few quick questions before moving on to the budget proposal on state hospitals specifically. Rep. Steele?
Just real quick, do we have like an ombudsman type of a setup where people outside of the hospitals to check on the facilities if they're for complaints and stuff?
Several. The Office of Recipient Rights is in the department, but not part of the state hospital system, and they make sure that patients' Chapter 7 rights are stood up in the facilities and do multiple investigations based on patient, family, and staff complaints. We also have a grievance system that is stood up through CMS. We have policies that reflect CMS standards about how to manage grievances, and then they review our grievances as appropriate. We also are accredited through Joint Commission, and they do triennial reviews and random complaint reviews at each facility several times a year. There is a triennial review process where they come in every 3 years, but several times a year they come in on specific complaints that families are advised, staff are advised, patients are advised they may make direct complaints to both CMS for the grievance system and to our accrediting body, the Joint Commission. And then there is, of course, also Disabilities Rights of Michigan, and patients have access to them directly as do families. So there are multiple systems. Yeah.
Rep. Green?
Thank you, Chair Morris. Thank you, Dr. Mellos. Where are we at in our bed census and our percent filled, and where do you see us going in regards to a greater need or whatever the case is? I have a couple follow-ups with you, but just questions there on our census.
Yeah, we're right now in terms of direct care staff, and you're only as good as the number of direct care staff that you have. And we're good to manage about 600 beds through the system. We have a census this morning of about 580 and are hoping to move toward 600, again, depending on direct care staff. It's been a little bit better the last 3 to 4 months in terms of people actually applying for direct care staff jobs, and I'm keeping my fingers crossed about that.
It's a common theme across all of healthcare. With our 600, can you give me a breakdown on the NGRI population versus non-court ordered?
Yeah, the forensic, in the adult services, forensic process, meaning NGRI plus people who are incompetent to stand trial and have been remanded to the facilities to be made competent, it's about 50% of the adult population. It's plus or minus 10 at any given time.
Great, thank you. And then the Walter Reuther Center, the old Walter Reuther, what are our plans with that facility?
Those are indeterminate at this time. There are about 10 acres there with that structure. I think you may have been there before, but it belongs to MDHHS, and again, what will happen with that acreage and that facility, indeterminate at this time.
Good deal. Thank you so much. Appreciate it.
And I'll ask the last question here. Can you tell us how many adults and children are currently on waiting lists for the psychiatric hospitals?
Well, let's go to kids first, and we work very closely with Megan's community services team in order to keep, we look at the wait list and talk about each kid on that wait list at least twice a week, trying to get them a service array in the community that can help them get off the wait list. So right now it's about 20. It used to be about 40, but working much more closely with the community services section team, we have been able to reduce that substantially. And again, that's through mechanisms like not just PRTF, but then also helping families and communities understand that they can mine the very rich waiver programs, SED, children's waiver, et cetera, in their communities to get the level of care like wraparound and supports coordination that they need in the communities.
And adults, do we know?
And adults, the probate list is between 40 and 60 at any given time. The forensic process list, we've been able to get down from 300 to about 200 at this time, and that includes people waiting in jail and people on bond in the last 4 to 5 months, and we're hopeful to continue moving that list down again through working directly with the jails to help get people restored in the context of the jail.
And is that limitation because of staffing? Is that why the wait list is where it?
That is a variable. There are several variables involved in why we have wait lists. Staffing is the most important variable, though. Yep.
Okay, well, thank you, Dr. Mellis, for your testimony today. We will move on to your budget requests.
All right, I will be very brief on these, as I know many of you are already familiar. Dr. Mellows routinely reminds me how we often think of the state hospitals because we can physically see them and we're familiar with the locations, but some of the community-based services are harder at times to visualize, but they are so essential and so important to make sure that we're meeting people where they're at, making sure they're being provided the services surrounded by their community, whether that's family, friends, whatever that looks like for them. And that is one of the reasons that we do have the significant investment in the CCBHCs, as you heard from Megan, looking to expand roughly around the 12 area of sites as we go forward in providing additional services to those in need. In addition, we talked about the MyCal investment, $7.2 million, so that is our 988 line that is available to individuals to call at any point, 24/7, and so the increase proposed in the budget is really to keep up with the volume of calls, texts, and other requests that we're getting through that. Next, we have a rate increase of 36.1, and this is for Medicaid behavioral health providers. We want to make sure that those on Medicaid also have access to behavioral health and that there are adequate providers in place. So this rate would align that with other providers and make sure that that access is available. Building on some of the workforce initiatives that we talked about previously, the fiscal year 2025 budget does include another investment in behavioral health workforce as we continue to look at a variety of avenues to make sure we're addressing the needs. There's $500,000 of ongoing funding, and this is intended to help those looking to complete their certification in the behavioral health field that may not have the means to be able to pay for those costs. And in addition, there's another $3 million of one-time funding to work with colleges and universities on internships and scholarship programs as we move forward. And then finally, we also have a nursing loan repayment program at $10 million. And what this is looking at is making sure that we are providing opportunities to pay off student loans for those going into the nursing field in exchange for that employment commitment. And this would impact those in various areas of the medical field, but also specifically in the state hospital. So the nurses in the state hospital would also be eligible for this program to help address some of the workforce issues we have there as well. And so with that, it concludes our fiscal year 2025 budget requests.
Thank you so much for those highlights. And I just do want to note that it is notable that the whole goal of, and this all started with the Olmstead decision back in the 80s, where, you know, the Supreme Court said the ADA says we cannot institutionalize people who should not be in institutions. So it goes back to that, and we understand that. And so that is, in part why the community supports are so important, and making sure there's that interconnected web of trying to get people what they need. So I appreciate your comments, Dr. Mouse, on especially the child's psychiatric wait list. It is really good to hear that you talk about those kids all the time and are trying to get them to the right place. We know the home is really often the ideal place, not always the ideal place for the kids to be, but it definitely, we understand that that is the healthier place typically for most people to be. So thank you for all your work there. And with that, any questions about the budget proposal? No. Okay, thank you so much. We will move on to juvenile justice, and we will welcome Senior Deputy Director of Children's Services Administration, Demetrius Starling, Director of Juvenile Justice Reform, Aaron House, and Amy Epke gets to stay right where she is and join us for this as well.
Good morning, Madam Chair and esteemed committee members. First and foremost, thank you all for having us. I just want to echo the sentiments of Megan before I get started, that the support that we receive from this group has been nothing short of amazing with Children's Services. So we really truly appreciate the collaboration, the input in regards to some of the work that we have in flight. So I'm going to start off our agenda speaking about our Keeping Kids Safe agenda, which is an agenda that looks to provide support and guidance to our families across the state. That was spearheaded by Director Hertel. This really prioritizes our youth in our systems and also the support that we can provide our families. Under these 5 particular pillars, there are a couple of things that I really find paramount that I want to touch upon today. So under prevention, you will see that we are investing millions of dollars to create more family resource centers, allowing Michigan to become one of only 5 states to receive the Child Safety Forward grant from the Office of Victims of Crime. This project really focuses on reducing or preventing child deaths that result from crime. The number of family resource centers recently expanded by 5 for a total of 11 across the state. Our family resource centers really work with our families that are at risk of abuse and neglect to meet their needs sooner than later and strengthen their protective factors. We've also improved our process for handling reports of suspected child abuse and neglect to our state's toll-free hotline, which is 855-444-3911, by creating a structured decision-making tool that better guides our frontline staff. We've also developed firearm safety protocols to provide guidance for our child welfare staff to talk with families about firearm safety. This includes creating a website with information about where families can get free trigger locks and appropriating $2 million to support initiatives related to misuse of guns, including trigger locks and other available options. Under intervention, we have developed an intervention tool that requires regular communication with our caseworkers and supervisors during key points of the CPS investigation. We've also worked with stakeholders and partners in the legislature, just like yourself, to support our child welfare systems. We've continued to identify policy changes to increase child safety. Some of these changes may include improved data sharing between our behavioral health partners, our substance use disorder partners, our DV partners, and child welfare system. We've also learned a lot about our child deaths by participating in multidisciplinary teams to really go over some of that information that we've seen in previous CPS cases with our MDHHS staff, practitioners, law enforcement, medical professionals, and others. Under stability, we've established a regional placement unit that helps identify appropriate living arrangements for our youth to ensure they are in the most family-like setting to meet their treatment needs. We've also created the Behavioral Health Board, which is our Bureau of Children's Coordinated Health Policy and Supports within our department, to improve and build upon coordination and oversight of children's needs and placement of children with complex needs. We've created an executive committee that provides support and accountability to our service providers in the child welfare system that are really not meeting our expectations. This committee provides an opportunity for leaders across our department and various administrations to holistically review the work of agencies and recommend interventions to ensure child safety. We've also launched ChildStat, which is a quality improvement process to make systemic changes to the state's child welfare system. ChildStat strategies include providing support for relatives so children can be placed with them instead of group residential facilities. Under wellness, we've increased funding for stronger basic needs to ensure families have access to adequate food, housing, and utilities. So really touching upon the work in regards to social determinants of health that this group is well aware of. We've increased access to quality mental health services to help families meet their needs. We've implemented a pilot project with local community mental health partners to connect families with mental health services as soon as children enter foster care. We've also implemented a standard behavioral health assessment for children across the state entering mental health systems for the child welfare system starting on December 21st of last year. Children far too often wait days or weeks to be assessed and identify what their treatment needs are, if any. Under workforce, we've implemented proven training practices known as motivational interviewing that provides all of our child welfare staff across public and private entities with enhanced engagement and assessment skills. Motivational interviewing is a new technique to encourage more engaging questions and allow for enhanced information sharing with the family. Also, we've improved the quality of ongoing safety planning for our CPS workers and supervisors. Safety plans include actions that families and people who support them are willing to take to prevent or respond to child safety or risk issues. We've also developed an ongoing quality assurance unit focusing on providing independent feedback to investigators to improve their investigation quality. And also we improve safety in group residential facilities by developing what is called the Residential Collaboration and Technical Assistance Unit. So next I'm going to touch upon how does Michigan's juvenile justice system work. So we continue to relentlessly work with our partners and stakeholders across the state to address the broad spectrum of needs for our youth across the continuum of child welfare services, when it comes to prevention all the way through the end of our systems. So system-level interventions ranging from low to high-level interventions, out-of-home alternative placements, onto community reintegration continues to be paramount for us. So when you think about our youth that come into our system, they can either come through our county courts via a petition. They remain in our child welfare system up to 19 or 21 if convicted of an extendable offense. And counties operate on a local probation system receiving funding through Child Care Fund, which Aaron will touch upon later. Our courts can take the following actions. They can use diversion programs, which we've really tried to touch upon in respective counties that have expressed interest in building upon some of their diversion programs. We determine competency to proceed in trial. We use our consent calendar, which are informal agreements between courts, parents, and youth on services. We also have a formal calendar that we process if youth are not meeting probation requirements. We retain case management or refer to commit a youth to our department. And also we receive funding, like I stated, through the Child Care Fund. We really want to kind of highlight some of the collaboration and that we've seen specifically in Wayne County. I just want to give them a big shout out with their CMO partners who have really stepped up some of their operations and some of their collaboration over the last year or so. You know, we contract, of course, with our CMO partners in Wayne County for case management services, and I just want to give them a shout out while I'm on the record here. Next, I want to touch upon our department's juvenile justice role. So under case management, we provide case management and conduct risk assessments of youth referred under our MCL or committed under 1975 PA 150 Act. We do pre-sentence investigations. We conduct pre-sentence investigations for youth who have been waived to our adult system but may be considered for sentencing as a juvenile. We do risk assessments, which we complete risk assessments, determine the level of care, and matching those youth to community-based services or residential services. We also supervise cases within the department. So as of January of this year, we supervise over about 447 juvenile justice cases, of which 211 are dual award cases, meaning that they both have an open neglect case and also a juvenile justice case. So with no further ado, I'm going to hand it over to Erin House, our Juvenile Justice Reform Director, and she's going to go over some key tenets in regards to juvenile justice reform.
Thank you, Demetrius. Good morning, Chair Morse and members of the committee. My name is Erin House, and as Demetrius said, I'm the Director of the Division of Juvenile Justice Reform. DHS created the Division of Juvenile Justice Reform in 2023. This division is solely dedicated to addressing problems identified within the juvenile justice system by working with state, county, and various partners to transform Michigan's juvenile justice system. Aligning policies and laws with best practices is a pivotal piece of the reform agenda. The Division of Juvenile Justice Reform is focused on building on the recommendations of the Task Force of Juvenile Justice Reform. The task force was established by executive order in 2021 that was co-chaired by Lieutenant Governor Gilchrist and Chief Justice Clement. The task force led a data-driven analysis of Michigan's juvenile justice system and recommended proven practices and strategies for reform that were grounded in data, research, and fundamental constitutional principles. Reforming juvenile justice requires a change in practice and in culture. It's reframing how a youth interacts with our system, including a shift from being punitive to prioritizing the health and wellness of the youth. Based on input from the courts, behavioral health experts, and various other state and local partners, the task force identified priorities around expanding diversion, increasing funding for community-based services and programs, providing additional tools to counties, among many other recommendations. I will briefly discuss some of these successes as of date, as well as some of our activities that are underway. The first recommendation from the task force was to enhance the Child Care Fund. On October 1st, 2023, the Child Care Fund was increased from a 50% paid by the state rate to a 75% paid by the state rate that will support in-home care and community-based services that will be provided for the youth. The increased incentives and supports are for the development, expansion, and strengthening of community-based services and formal alternatives to detention and incarceration. Out-of-home care reimbursement rate will remain at 50% paid for by the state. MDHHS is working closely with the State Court Administrative Office, counties, and other partners to provide guidance and continually monitor the rollout of the new reimbursement and evaluate the successes. While MDHHS continually looks for new opportunities for community-based services, the department also recognizes the necessity of secure residential treatment for specific justice-involved youth who cannot be safely treated in their communities. To address this need, grant funding has been awarded to partners to help expand over 100 placements as shown on this slide. The department is committed to continually evaluating the level of kids in residential treatment and adjusting as needed to best meet the needs of our youth. In addition to supporting community-based services and expanding placement opportunities, MDHHS routinely looks for new approaches that may lead to success. MDHHS was recently awarded a federal planning and assessment grant of $825,000 to improve Michigan's juvenile justice system by prioritizing the well-being and future potential of youth and families involved in the system. This grant was awarded by the Juvenile Justice Delinquency and Prevention Unit of the DOJ. MDHHS will use this grant to develop a plan that focuses on specific data-driven, evidence-based approaches for prevention and intervention services for youth at risk of involvement or already involved in the juvenile justice system. And finally, the department kicked off the Michigan Juvenile Justice Advisory Council. Council members on the advisory council are former juvenile justice youth or their families who are passionate about sharing their voices and experience to help Michigan's reform efforts. The Advisory Council will assist with developing recommendations on job training, skill development, implementation of juvenile justice policy, and other efforts to enhance Michigan's juvenile justice system. At this time, I will hand it over to our Senior Deputy Director, Amy Epke, who will discuss our proposed fiscal year 2025 investments. Thank you.
This morning, there's actually 3 investments I want to touch on. 2 are included in this presentation, and 1 we touched on last week, and I just want to make sure that we talk about the connection related to juvenile justice. So when we talked about the child welfare presentation, there was a $38 million increase for rates and contracts related to 24-hour residential care, both for on the child welfare side and on the juvenile justice side. So that's a significant investment included in our budget. We did have a good conversation yesterday with the CCIs in terms of that proposal, and we provided an opportunity for them to provide feedback on our proposed contract structure and rate structure, hoping to collectively evolve that structure as we go forward. In addition, this slide that's on your screen now shows a $6.9 million proposal for juvenile justice specifically, and that is related to implementing some of the recommendations around the task force, such as the risk assessment and a number of other tools that will be rolled out over the upcoming years. In addition, there's $5 million of one-time funding for Bay Pines and Shawano, which are 2 state-owned juvenile justice facilities. And then finally, I want to touch on the Medicaid community reentry proposal. This one might not necessarily jump out as linked to JJ, but it certainly is. This proposal is designed to provide Medicaid coverage for those in correctional facilities or juvenile justice facilities prior to reentering into the community. And so this would be an opportunity to make sure that they are set up for success. This could include things like prescription drug coverage as upon their release in other areas as well. So again, this one is an important investment for us as well. So with that, I can wrap it up and open it up for any questions. Thank you.
Thank you, team. Thank you for your presentation and your work in this very challenging area for our, really vulnerable kids. Amy, I want to follow up on the community reentry real quick. So are you saying that children who are in juvenile justice are also not eligible for Medicaid while they're in a facility?
I may actually have to bring Megan back up on this one, but what this would allow is would allow coverage prior to release, and then some services upon as well. And we do need to get a waiver from the federal government on this, 1115, but I'll certainly have Megan talk more about the specifics.
No, that was absolutely right, but I thought maybe I'd help out. So in terms of your specific question, so children in a juvenile justice facility are eligible for Medicaid if they're eligible, right, based on income and all of those other eligibility pieces. We cannot reimburse for their services inside the 4 walls of a facility. So if they are getting services inside a locked juvenile justice facility, we cannot reimburse for those services in the Medicaid program. There are instances where people are taken outside, maybe somebody needs to go to a hospital or something like that. Those services that are not in those 4 walls are reimbursed if they are eligible. This has been the answer on Medicaid for years and years and years and years. And then a couple years ago, CMS started talking about opportunities for in-reach programs. And so this wouldn't necessarily be for all services all the time, anything in an institutional setting. What it would be is prior to release for an individual in a juvenile justice facility or in other correctional institution, you want to have that continuity of care that we were talking about, right? So can you have the people who are going to be serving that individual on the outside come in earlier so they develop that relationship and have those services delivered there, and so that when they transition to the community, we can, that is a piece that will have that continuity of care. We are talking with CMS right now about what a waiver would look like in Michigan, and we are looking at kind of, you can do a couple different options, but the maximum that they are allowing is maybe a 90-day in-reach for us to deliver those services within the walls. Am I answering your question?
You are, because, for some crazy reason, I guess I assumed that children in juvenile justice would be exempt from the fact that we can't provide Medicaid for those that are in incarcerated. I didn't realize that they're not eligible for Medicaid, and that is insane. So even those children that would have been receiving services, like let's say half of them are in abuse and neglect cases already, and they may have already been connected to services. So if they go into JJ, then they get disconnected from all of that?
So if they're in a lockdown juvenile justice facility, I am not an expert in JJ, so step in here if I get any of this wrong. But for example, if you have a youth being served in the community on a tether or something like that, that's something that Medicaid could be involved in. But if it is in that lockdown facility, we can't reimburse for services there. And I should say that Michigan is working with CMS, but nobody is currently doing this in the JJ space right now, and we would like to work with CMS and kind of be a leader in that space.
So any behavioral health services, for example, that you're providing in those secure facilities would just come out of the funding that you receive from where? How do you cover that then?
Yeah, so those kids can either be Title IV funded or county funded, so we can't cross over funds with Medicaid as a result.
Okay, so
Yeah.
the counties have responsibility for that
Correct.
as well? Okay.
Correct.
Okay. Just as they do for our jails, no matter what someone is ill with who's sitting in our jails. It's crazy. Okay. Questions? Rep. Farhad, I'll let you said you'd save your question?
You know, I wanted to ask a little bit, thank you, Chair Morse. I wanted to ask just a very high level, you know, juvenile justice is a very important area, especially when we're talking about adolescence, very early age, a lot of life just to look forward to. Is there ways we can be more proactive on the policy side? Are there policies, are there certain interventions that, and I know we're talking about, you know, kind of the throughput, right? So they're in the system right now. Are there things that we can do to prevent the input of more juveniles into the JJ system? Which I think, you know, for me is again, I'm a young person sitting here. I would be sad to say, I'd be lying if I said I didn't know people that unfortunately got into this system, who I went to high school with or, you know, no longer keep in touch with, unfortunately, because they're locked up. It's a sad story, but how do we break that cycle in the opinion of you folks here? Maybe some interventions that we could explore. I'm not looking for the silver bullet, but maybe some high-level ideas.
Yeah, so I can touch on a couple of things here. I think bipartisan legislation that we all can see from you all to help us really see some of the recommendations that Lieutenant Governor Gilchrist signed off on last fall would really be helpful. Also, when we think about some of the ideas that we fielded from our young adults who have either been impacted by our systems or who are part of residential advisory committee meetings, I think it would be really beneficial for you all to hear directly from them about ideas on how to enhance our systems. You know, it's one thing for them to relay those ideas to us, but to hear from folks who are best situated in our communities like you all, that maybe you can bring back to your respective groups to talk about how you can work on legislation to assist to get those things in flight will really, really be helpful. Yep.
Rep. Green.
Again, thank you, Madam Chair. Thank you guys for being here. Obviously, the child population is a huge population. We've watched things expand and contract and expand and contract, specifically on licensing of some of our community-based placements for some of this juvenile justice. But yet we have some facilities that are being overpopulated or right there at the brink. I can think of a couple county facilities. Can you talk to us a little bit about some of the steps you guys are doing to try to move, to stop that backlog or to push open that hourglass so that we can get some of our children moved out?
Yeah, I'll start that off and let Demetrius add on. So one of the things we are looking at is exactly that, right-sizing our contracts. So you've said it really well. In some cases, you know, we have more beds on contract, but we have a waiting list, and that just doesn't, you know, make sense. So we've looked very closely in terms of what the CCIs can provide in terms of number of beds of services, and we met yesterday with them, a proposal of 560 beds total. That would be 435 abuse neglect and 115 on the juvenile justice side. Apologize, that was 445, sorry, I think I said 435. But 445 on the abuse neglect and 115 on the JJ side. And so now what we're looking at, does that meet their business model? Can they commit to that going forward? And then we'll make sure that we provide through our new contract structure that certainty in funding and continue to work with them to be evaluating. What we ultimately want to make sure is that anytime we have that child that needs services, there is that bed available and that guarantee of a bed as we move forward. So I think, you know, we're really committed to working closely with the CCIs to make sure we can right-size those contracts.
Okay, so we're hoping eventually that bottleneck's going to start moving and we can move kids to better facility or more, I'm going to say better, more appropriate facilities.
Exactly. And we're hoping through this model too, I think for the CCIs specifically, I mean, they need that level of certainty as well too, and I think this will help with that as we move forward. Now, certainly, we anticipate there will be feedback that we'll hear after yesterday's conversation with them, and we want to take that feedback and make sure we adjust the model as needed as we go forward.
Okay. And I guess a second question along with that, we know that education is really the key. People who are literate and people who graduate generally don't get involved in our systems. It used to be that there was an individual or maybe a group of individuals that were responsible, like an education liaison, that made sure that their CA-60s, their education records, moved to the different areas with them. And then there was a time frame where that sort of went away. Can you talk about your interaction on the education side of it with our students that are in the system?
Yeah, I can speak to that in regards to our state-ran facilities. So, ironically enough, Aaron, myself, and the Juvenile Justice Director, Holly Force, met with the Department of Education at our Shawano facility just last week to go over some of that IEP work and how we can better work with some of our ISDs in respective regions, really trying to enhance some of those services as far as special education, making sure that we have a keen focus on potential contracts we can bring into the facility to help with some of those educational services. So that is something that's really paramount for us. We're going to continue to kind of push the envelope because we know that the kids that come into our systems are really at risk because of them being back and forth to different facilities. Sometimes they miss out on education requirements. They don't go to school at the same rate we see other youth. So we want to make sure that we step up our efforts to make sure that they receive the right services. Yep.
Brett Price.
Thank you, Chair Morse. Under the Keep Kids Safe Action Agenda pillars and intervention, you recognize the conflation of poverty with neglect as being a problem. Could you talk a little bit more about that, how that has impacted our youth in the past, and what the department is doing to avoid conflating poverty and neglect?
Thank you. Great question. I really appreciate that. So I think that our department has done a really good job steadfastly working to re-envision our policies and practices around that. Poverty should not be a reason why a family is dismantled. Poverty should not be a reason why a family cannot be reunified. So we are putting not only actions up in the front end as far as re-envisioning our policies and practices, but we're also looking at specific models to provide concrete economic supports on the front end to families that are in need. So we have what is called the family impact teams, and they are specialists that are situated across the state. Right now, we're in 12 counties, looking to expand phase 2 here, coming up shortly, that we're going to have a specialist situated in each and every child welfare unit. So whenever a call comes into our hotline and there's a concrete or economic need that's brought up, we're going to have these folks work in regards to housing instability, food insecurity, lack of access to mental health services, lack of access to medical services. So we combat and we tamp down on all those issues so we can kind of close that front door of CPS interaction and open up a larger door to prevention for our families. Yeah.
Last question, Rep. O'Neill.
Thank you, Madam Chair, Madam Director, Senior Deputy Directors, and your whole team. Thank you for this information and the work that you do. I have a myriad of questions, but I'm going to try to narrow it down real concise. We already know that we're short in bed space. that's a parent. My concern is in terms of, those students, those kids who are in the system, first, their assessment. How's that impact the determination of in-home services? And then second, sometimes assessments aren't always accurate. And so that's always a concern of mine. But in terms of the area, Madam Director, you mentioned retain case management or refer or commit a youth to DHSS. So my question is, so what happens in terms of family reunification activities when that child is referred to DHSS as a ward of the state? What are the processes for reunification with a ward of the state?
Okay, Aaron can touch on the assessment tool, and I can touch on the permanency piece. Yeah.
Yes, thank you, Representative. That's a great question that we are working on right now and using the tools that were just passed. So legislation was just signed this December that gives us and our reform team tools to work with our partners across the state and county on the risk and needs assessments, mental health screening tools, and these tools will be used in various parts of the hearing to enhance, to divert and do consent calendar for youth who do not belong in the juvenile justice system at all. And then based on their risk and needs from that assessment, then they will be matched with community-based services that will help them stay in their home and receive the appropriate care that they need. Conversely, when we use these risk and needs tools throughout the hearing, predisposition, then that will help determine whether a youth can be served in the home, in the community, or in a residential detention facility. And so those tools will be are being capacity built into the system right now. Some counties are already using them. And for the accuracy of the tools, these are evidence-based, validated tools. So if the tools are used to the fidelity of the tool, then they are statistically known to be successful. However, there are certain situations where a judge may know that there are extenuating circumstances that might not be reflected in that tool, and in that circumstance, the judge has the ability to override the tool. So there is some flexibility built in there based on what's happening in that community. But we are going to be expanding those tools. There will probably be 3 or 4 tools that will be used statewide once the implementation of the reform efforts beginning next fall.
And to your question about permanency, so permanency discussions start on day one for system impact youth, whether they are neglect children or JJ youth or dual ward youth. And when I say day one, we have the parent agency agreement, we have comprehensive case reviews that occur between the case manager, the probation officer, and the facility to make sure that that plan that's been implemented, once the tools have been utilized for that youth to do that really comprehensive assessment, that we're looking at the right services, community reintegration processes, folks in the community that can potentially be supports for those youth if they are able to be stepped down to either their parental home or another family-like setting. So those start on day one. I mean, and we just work steadfastly towards making sure we approach that with a lot of aggression and vigor, because we want these youth to be home sooner than later.
Madam Chair, if I may just follow up briefly. Well, this is a continuation of, so on the reunification part, with our bed space being the way it is, a lot of our kids are sort of like in a holding pattern, if you will. I consider like this, our system should be like a triage in the hospital. You go into the emergency room, you don't want to stay in a hallway in the emergency room because you're not getting the service you need. It's exacerbated if you're in the hallway for an extended period of time. The analogy in the hallway is being maintained in a cell confinement because you're not getting the service, you don't have the bed space. So that's a major, major concern of mine, I'm sure of my colleagues, in terms of us, triaging those kids to where they need to be. As you eloquently said, the main purpose is to reunify that family with that child. And so I'm very concerned about that, seeing the fact that we don't have space to send these kids for treatment, but they're in a holding pattern in some of our confined places. So.
Yeah, so we share in those same concerns. I think that, prevention is key. So looking at different ways to protect and support our youth who could be impacted by our systems on the front end, whether it be, diversion programs, making sure that these youth don't even have to come to our attention at all, continues to be something that we keep as a focus, but absolutely. And, I will say this, that, some of our youth, we've heard stories about youth having to sleep in offices or, in other inappropriate settings. That has really started to be on a downward spiral, as of the last year or so, because of the ideas that have been brought forth about community reintegration and diversion programs. So, that's something that's not lost on us, and we're going to continue to work to turn our systems towards equity for our kids. Yep. I know you will. Yeah, absolutely. Thank you, sir.
Well, thank you so much to the team for being here. We really appreciate your information and your work. We all care about making sure that our kids have a fair shot at life. So thank you.
Thank you, Madam Chair.
Next, we'll move on to Chris Mattis. He's joining us from Wayne County. And I'm sorry, members, we're going long today. Chris has about 5 minutes, so if you can be patient, and then we'll wrap this thing up.
Well, good morning, everybody. Thank you, Chair Morse, members of this committee. As was stated, my name is Chris Mattis, Director of Government Relations for Wayne County CEO Warren Evans, and I will be brief. Frankly, I'm really grateful. I've had the opportunity to meet with a lot of you individually, and clearly the issue of juvenile justice reform, and particularly one thing that I'm going to speak to is the need for additional secured treatment beds for juveniles is something that's really front of your all's mind. And I appreciate that. I appreciate the hard work of the agency, and I appreciate the work you did passing the juvenile justice reforms at the end of last year. So with that, I would also like to thank, while I'm thanking people, Governor Gretchen Whitmer for really recognizing the need to make some serious investments in not only expanding our capacity for juvenile justice secured residential beds, but also reforming the system so that the community-based centers that we are relying on have the resources they need and the support they need to be successful. The need may look different, but the reality is statewide. Whether it is a young person in the Upper Peninsula who cannot afford or find the inpatient mental health care they need, or an adjudicated youth in the Wayne County Detention Center who should be receiving treatment in a community-based secured facility, but simply has nowhere to go. And to give you a little bit of context, I got a text from our Director of Juvenile Services while I was sitting here. Right now, out of the 106 juveniles in the Wayne County Detention Center, 64 of those have already been adjudicated. So about 60% of the youth in the Wayne County Juvenile Detention Center should be somewhere else right now receiving the care and the treatment that they've been sentenced to by the judge and that they need really to turn their life around and get back on the right track. Of course, the challenge in Wayne County of finding placements for adjudicated youth has unfortunately been well documented. But we have made some really significant and direct investments in our juvenile detention center, which I wanted to highlight quickly. The county's increased salaries for staff, filling positions and improving staff to youth ratios. There are new programs like a student council, which gives residents an opportunity to make decisions on daily programming, schedules, and rules. There are more opportunities for family visits, including holiday celebrations and meals. And the food is better. This year, the county will also be moving into a new criminal justice center, which will also have an increased capacity of beds for youth in the detention center. But I want to make something clear that I think you all understand. Even if the Wayne County new Justice Center has more beds, even if we fill all 106 of our beds and there's not a single one person who needs a bed in Wayne County, we are not set up nor are we intended to be the treatment center. We are a temporary detention facility until those youth move on and get the care that they need. And in addition to trying to make improvements to our own detention center, Wayne County really has been a leader in working with our CMOs and our partners to divert youth when we can and to release people to tethered supervision when we can. Although I will also be honest, that is imperfect and sometimes a little disconcerting. There are many released on tether right now, juveniles as old as 17 years old, who have been convicted of a capital offense. Carjacking, sexual assault, homicide. And if I may divert from my statement for one quick anecdote that really, for me, tragically illustrates the trouble and the need for these secured beds, there was a youth in Wayne County who was going through the criminal justice system waiting for placement in a treatment center. They were released on tether. while they were released on tether, they themselves were the victim of a homicide, right? So they were home in the community, but unfortunately, while they were waiting, they fell victim to the same environment and challenges that perhaps got them into the system in the first place. That was an individual who should have been somewhere else getting the secure treatment they needed. The truth is, even with the recent juvenile justice reforms that increase diversion and community-based care, there are juveniles who need secured treatment. As I said, a county detention center is not intended for that long-term treatment center, and local communities need the state of Michigan's help to ensure that youths in crisis receive the proper care that they need, whether directly from the Department of Health and Human Services or through a robust and supported network of community-based treatment centers who are supported by agency rules, licensed appropriately, and funded at a rate that really helps them complete and serve their purpose. So with that, I would just say thank you again for your attention to this issue. I'm happy to help facilitate a meeting with leadership at Wayne County if any of you have any additional questions. And happy to answer any questions you might have for me, and hope you have a good day. Thank you.
Well, thank you, Chris, for being here and sharing the Wayne County perspective on this subject. I think you all know how to get in touch with Chris, so you can follow up with any questions you have. Not seeing any at this moment, so Vice Chair Green moves to excuse absent members. Hearing no objection, absent members are excused. And seeing no further business, this meeting is adjourned.